Oncology.TV here at ASH 2013. Always a pleasure to have with us Dr. Claire Harrison. She is from the Guy's and St. Thomas NHS Foundation in London in the UK. Thanks for being with us.
No problem, pleasure.
Let's talk about the research you have being presented here at ASH 2013, the pooled overall survival analysis of the COMFORT studies, randomized phase 3 trials of Ruxolitinib for the treatment of myelofibrosis. Can you give us an overview of that first before you get into the results?
Okay, so if you remember, the COMFORT studies are a pair of sister studies, which are the first studies with the JAK inhibitor Ruxolitinib, which led to approval of this agent for treatment of myelofibrosis. The two trials, one in North America comparing the agent against placebo and the other in Europe comparing the agents against best available, i.e. standard therapies, were first reported in 2011. An unexpected and very gratifying benefit which has arisen from these studies is that this agent, Ruxolitinib, appears to prolong survival of patients with myelofibrosis. Neither study was powered to show this, and our analysis of this data has been hampered by the fact that, due to ethical reasons and because of the strong benefit of this drug, the patients were crossed over from the control arms in the trial to Ruxolitinib. And so the analysis that we present at this ASH meeting, one of several with this agent, is a pooled analysis of these two trials, which we could do because the eligibility criteria for the studies are very, very similar, and also allows us to pool together the control arms. The analysis also uses a fancy statistical test to counter the effects of crossing patients over. This is a statistical tool which is approved by the FDA and the EMA. And so essentially the results of this data strengthen the survival message from Ruxolitinib, but they go beyond that and they show us that there are factors that impact upon survival. Some of these are already well known in the disease area but haven't been assessed for Ruxolitinib. They include, for example, age, hemoglobin, white cell count, etc. But something else that emerges is that for every 5 deciliters increase in spleen volume at baseline, likelihood of benefit was less. And conversely, because the drug's primary action is to reduce spleen size, for the patients with a greater degree of spleen benefit, there was greater survival advantage. However, of course, patients with lower spleen reductions also had survival benefit. So this is a very important and strong analysis because the durability of the studies is now much longer and the strength of the message is therefore stronger.
This is very exciting, this work that you keep having with Ruxolitinib. What's that like for you to keep getting surprising results?
Well, it's very gratifying, of course, and I think I reflected in an interview with your team in the past that, this is perhaps one of the most important things that I've been involved in my career to date. So it's very, very important for me that I see that the integrity of the data is still really strong, that the drug is still doing very good things for patients, and that we continue to learn new data from it. So another example, if I may, from the data that we presented in a separate analysis at ASH, is to look at the COMFORT-2 patients and look at the impact of molecular markers upon the survival benefit. So the two groups from Florence, led by Alessandro Vanucci, and the group from the Mayo in Rochester last year at ASH described that if patients have one of a number of mutations, they are at molecular high risk, have a reduced chance of overall survival and a higher risk of developing leukemia. And so what we've been able to do and present this year is analysis of these mutations in the COMFORT cohort, show that they're very prevalent, show that they don't appear to be increased in patients treated with Ruxolitinib, but also show that Ruxolitinib treatment appears to be beneficial for both high and low molecular risk patients, and that the treatment of the higher risk patients with Ruxolitinib appears to improve their survival to be more similar to those of lower risk patients. So the story is walking hand in hand with science, if you like, to tell us a little bit more about benefits for the disease.
So where will you focus next?
So I think our next strategy is to try to move forward in our understanding of pathogenesis, and some very exciting data at this year's ASH, 2 late-breaking abstracts describing mutations in a completely new gene in the field, calreticulin, showing that now we can find a mutation in up to 97% of patients with MPN, showing some correlates in terms of clinical outcomes. So we've been involved with the groups discovering this mutation. We would like to bring this to clinical practice and understand its impact as a therapeutic target. I would like to move forward in strengthening our armamentarium of drugs for patients, because some patients, very few initially, but some patients initially and some patients over time might lose their response to ruxolitinib. So I'm keen to be involved in development of other JAK inhibitors. There is data presented at this meeting with, for example, pacritinib, momelotinib, the BMS compound. I'm also interested in other targets like imetelstat, telomerase inhibitor. Our group in particular is focusing upon combination strategies with ruxolitinib. We've been very heavily involved, for example, with panabinostat in combination with ruxolitinib, and the newer strategies such as inhibiting PI3 kinase and LDE, the hedgehog pathway inhibitor. So I think my focus, certainly in terms of clinical trials, will be to try to push forward data with regard to clinical trials. I would also like to see and would support development of a better endpoint so we can pick out which patients are going to respond better. Moving beyond spleen and symptoms, they're important clinically, but we need to understand a bit more robustly a sort of pathogenetic level, if you like, what's happening to patients and which patients might be better treated with which strategy. So a busy few years ahead, I think.
You will be. Congratulations on your findings and best of luck in creating better patient outcomes.
Thank you very much.
Thanks for being with us as always.
No problem. Pleasure.